You're busy, you've got a decent practice, but nobody wants to be decent. You want to be great, and you want to have a great practice. So how did the most productive, profitable dentist in the nation balance real life, work, and profits, and somehow make it all seem fun? Well, it comes down to simple, everyday practices. So grab a lunch, join us as we chat with top clinicians and influencers to discover their formula for uncommon success. Are you ready? Then it's time to explore everyday practices with Vicki McManus-Peterson and Dr. Chad Johnson.
Hi, everybody. Welcome to Everyday Practices with Vicki McManus-Peterson. Hi, Vicki.
Hi, Chad. How are you?
I'm doing well, thanks.
Wait. Do you notice my...
You wore them. Yes.
I'm wearing.
Bacon and eggs.
Only on our podcast can you pull off such earrings.
Where no listener can see that you're wearing bacon and eggs on your earrings, but nonetheless, everybody, please enjoy the aroma of her earrings. It's not real bacon and eggs, I'm sure. Right?
Right.
Okay. So today we have a special guest, Patti Sooy, the $60 million coach. Patti, thanks for joining us today.
Hey, it's a pleasure to be here.
Yeah. So one of the things that we wanted to talk about today was you just wrapped up with the workshop for Productive Dentist Academy. We have 3 of those a year. Can you tell me what went on there and the excitement? Kind of fill us in for those that don't know much about that.
Well, we had an exceptional program this time and a real exciting celebration since PDA just completed their or are in their 15th year of helping dentists improve their practices and grow and become super productive. So that was a lot of fun. We had a wonderful gala and got to get all dressed up. But most importantly, at those, and any workshop that we do is really all about the doctors and the teams that are there. And we really work to give them as many tools for their toolkit to take back to their offices and create change that will impact them and their patients in a very big way. So we changed some things up this time, and I thought it went really, really well. We had a great group of people there.
Yep. And all within 48 plus-ish hours. It's interesting to watch teams transform from feeling disenchanted or frustrated or whatever to feeling empowered that they could go back and do something about it. Because a lot of times I think people might, or team members might think, okay, what are we going to do and how am I going to get dragged into this? As opposed to when I get home, we're going to change this and I feel like I can help do my part to make us the best possible and we're going to knock this out of the park. For example, I was talking with the Karmazines just recently this last week and they said, man, we are just on cloud 9. Everyone is just rocking it out. I was actually kind of concerned that they might be frustrated because that's going to naturally happen. But they said, we're still rocking and rolling. I was like, good for you. Keep going. So that's awesome.
Saw their mailer that dropped last week. It is beautiful.
Cool.
I love the way our education and the consulting play together, and then the marketing kind of supports all the messaging, right? It's so custom to the tone and the message of the practice, you know?
Well, one of the things that we always do evaluations after any event, and we do that because we want to get better at what we do. And, we get a lot of great feedback on those and a lot of high scores, and yet we still always are trying to learn. And one of the things that one of the Dr. Karmazine said was, this is the best CE I've ever been to. And I'm more excited now than I have been in years to take back and put into play relationships. And I heard that several times this time. This was the best CE course, not just from doctors, but from team members that I've ever been to. And so that's really encouraging. And they give us such great ideas of what they'd like more of. And that's why we change things up on a consistent basis, because we want to be able to impact teams in the best way possible. And dentistry is always changing. So that's what we get to do.
That's awesome.
Patty, break that down a little bit for us. One of the specific things that you teach, and you and I have known each other for 20 years. I admire you so much, not only on a personal level, but professionally. For those who don't know, Patti Sooy has been the director of coaching for quite some time at Productive Dentist Academy. And before that, she is, let me make sure I get this right, an expanded function restorative dental hygienist who's laser certified, preceptor trained through the Bale-Donine method, managed your dental practice for 23 years. So you're like this wicked smart combination of clinical astuteness. I mean, you're a restorative hygienist. That means you are compacting the composites, you're curing it, you're carving the anatomy on it, you give anesthetic. The only thing you didn't do was prep the tooth. So when it comes to case selection, when it comes to material selection, when it comes to knowing occlusion and functionality, oral cancer screenings, oral hygiene, oral systemic connections, I mean, there's very little that gets past you, and we're so blessed that you help dental teams understand how to look for patient risk factors, how to develop their standard of care. So can you walk through, like, as Chad was saying, like, you leave ready to do something, and when our coaches go in office, you're ready to do something. What is that something based on?
Yeah, that's a really good way to break that down. And what I find is, and the other thing that I really enjoyed doing in private practice when I was clinical was new patient coordinator. So I would often, most of the time, see the new patients in the restorative side with an assistant, and we knock out a really great new patient exam. And so we went over risk factors. We went over their risks and we talked about them. And so they were all prepared when the doctor walked in. And it was just a separate appointment. It wasn't necessarily a cleaning right then. They went into hygiene from there. I didn't always do the cleanings. And so the risk is what's so important. And I don't always know if I get that across to doctors and teams. I don't always get to talk to the teams at the events. But in the breakouts, I always want the doctors to know this is your homework. This is critical to establish your standard of care. You must know what your parameters are for each risk. And I always talk about the top three: caries, perio, and function. Those are the three that I talk about most. And there's other ones. And if they treat sleep for sleep apnea, those sorts of things. But the big three. And you must know what your parameters are for setting what's healthy or low risk, and then what's high risk. Because your moderate's going to fall somewhere in between. So what's healthy, what's not healthy, and when is it, what's high, what would you consider high risk? So you establish those parameters. When I see this is what I do. Okay, this is what makes it high. Okay, so everybody on the team knows. And that's the key right there. Everybody on the team knows. Because what doctors normally do is they talk about, they might know that in their head. They might say, well, yeah, this is a high risk, but they don't speak it. They don't speak it with their team, and they don't speak it with their patients. And so the patients don't know why that's happening in their mouth. They don't understand what's contributing to this disease they're experiencing in their mouth. They don't understand it. They don't understand the genetics, the inflammatory response that we should be picking up on the medical history. And so once you do that, then you have to establish, okay, now I know where low, moderate, and high, but especially low and high are. And now when that shows up in our practice within our patients, what do we do to lower the risk? What are our recommendations besides only treating it in the chair? What are the other things that we recommend, or products we recommend, or changes in self-care at home? What do we do? What do we typically recommend when we see this? And that everybody on the team knows. So that's what I think is, it's the foundation of everything. If you don't know that, you're all kind of swimming in different directions. It's a little chaotic.
You know, that it sounds like a lot, and I know you have an easy way of teaching it. You touched on medical history, you touched on genetic factors, you touched on home care. I love, because, you know, back when the Dead Sea was getting sick, I was the hygienist, and so I love the preventative piece in this, right? So when you're talking about risk factors, the way that we teach it, when you're talking about that, it really helps the patient become educated to what they can do and how you can work together. So how do you make this simple for the teams to understand how medical dental history impacts treatment planning and things like that? Or is there a way to make it easy?
Yeah, I think so. I think it's a team exercise that you do. There's a, some different ways to approach it, but what I have found works the best is I really ask the doctor before coming into this. I ask the doctor to come into it prepared with their parameters and protocols, and then we move into a team discussion about that after we do this one exercise. And I think this is a really powerful exercise that more offices need to do. And you can do it without a consultant. It's just that when you have a facilitator to help you, it just moves it along. So I have everybody get a blank medical history and dental history. It's got to be both. Medical dental history, and it's blank, and they all have a copy of it. And they need to have a clipboard. They need to have a pen or a pencil and maybe even a highlighter. And I have them look at that, and I say, okay, so when you're looking at this, you know that there's low, moderate, and high risk. So if a patient comes into your practice and they circle a yes to any one of the conditions that you have listed in your practice, what do you do with that? What do you do with that? What does that mean to you as a provider? And what does that mean to the patient? And what's maybe going to be going on in their mouth combined with their medical conditions? Some, oral systemic connection. I always call it the infection connection. When you have infection in your body, you often have infection in your mouth, especially if it's inflammatory. So I have them look at that. And anything that if they circled yes to, what risk of the risk factors would it affect? And so they have to write on it. I think I have it as, if they do airway, I have it A, B, C, caries. B is what? I may not have put that right. A, bite. Yeah, it is. So airway, bite, caries, and then I just put F or P for perio. So if it affects one of those risks, I just have them write it by it if they circle a yes on it.
A, airway, B, bite, E, caries, D, dang, your breath smells bad. See, that's
nice.
There you go. The ABC of risk. Yeah. The ABCs of risk. So, what's really powerful about that, though, we do that, and then I pause, and then because then they've gone through all the questions, and then I pause and I go, is there any one of these questions that's being asked that you don't understand the connection with anything in dentistry? If they answer yes, do you know how to dive deeper into that question? Because what amazes me is how many times people get a standardized health history form and they use it, and then there's questions on there, and they don't know why they're on there. They don't know the impact it might have in dentistry or medically even. They don't understand how to ask a patient a question about, okay, so if they have something like, I'm going to just put it out there because it's an awkward one. If they mark venereal disease, what do I do with that? If they say yes, what do I need to do for follow-up? Because questions are either on there for a reason, and we have to know how to explore them more, or we shouldn't be asking them. And we can't be embarrassed about it. We're healthcare providers, so we have to know how to deal with uncomfortable questions, and we have to know how to, like gout. What does gout have to do with anything? So it's understanding all of those things, and it's a great discussion tool for the doctor to shine. And sometimes the doctor will even say, I don't know why we asked that. Or they're still asking questions about scarlet fever or some different things, or they say fits and seizures instead of just seizures. And so it's a good way to go through it and update it. So
how often should teams go through that?
Huh. That's a good question.
Yeah, I do the standardized, but anytime a new team member comes in, I think it's an important thing to do. So if you're going through team a lot, you should make sure you're reviewing it, because that's the time you review your standard of care, your risk factor, parameters and protocols, and your health history.
So this should be so clearly articulated, maybe even videotaped by the doctor or recorded, and it should be a part of the onboarding process. Here in our practice, this is what we believe. So when a tooth looks like this, we do a root canal versus looking like that, we do an implant. This tells us it's cracked. This tells us.
If only. Yeah.
Well, and that's part two. That's part two of that standard of care. So now we've gone through the health history, we've gone through the risk. Now we do part two exercise, which is case study, which I call a calibration exercise. So the calibration exercise, right? So then we pick out a case of a current patient. And, you want to kind of start with an easy one just to get everybody, on the same page. But you look at that now, we've gone through it. Everybody understands what low, moderate, and high is and what our recommended suggestions are for the patients. And then then you go through it. And what I do is I have them pull it up. If I'm there, what I love to do is I love to pull it up on we have a hygienist, depending on how big your practice is, a hygienist, an assistant, and an admin. And I kind of leave the doctor or doctors as either working together or roaming and just kind of observing. Because the doctor is going to share their recommendations, their treatment recommendations at the end of this. But in the meantime, what we do is we have the team. I pull it up on everything, and I usually put a Post-it note over the patient's name. Because a lot of times what I find is that if somebody's worked on that patient recently, there's a lot of stories attached to it. Same with the health tree. I try to print those off, actually print them and give each workstation, a copy of it with their name scratched out. So there's not any stories attached to why I didn't follow up on that. And then, so then they have all that. And what they do is they review radiographs, photographs, their medical dental history. Dental often gets missed on this, by the way. Medical dental history. And then what am I missing? Radiographs.
Periochart.
Periochart, yes.
You were testing me.
Yeah, I was. Thank you, Chad, for time.
And for those who are tuning in, now you see why I have such high respect for Patti. I mean, this is the depth that our coaches go into in consults in office. So if you're a PDA client and you haven't had this type of consult in your office, talk to your coach. Let's spring into fall here. Let's get ready for the summer. It's a great summer camp exercise. Recalibrate.
Well, and Vicki, what you just said earlier is if you may not record the work session, but you would record this then after, once the case and the doctor starts sharing, here's what I'm recommending and this is why. And, so they do this. And so there's a whole case study. In fact, I've done this in doctor breakouts before at our events, and just to get the conversation started so they can see how to do this back in their practices. Because when you're bringing on associates, when you're bringing on new team members, this is really important stuff to do as basic training. This is your basic boot camp.
You did this in my West Salem office, and I'm going to say that two things happened. Number one, treatment plans increased because you only recommend what you see. So they started seeing things through the risk factors, and oh my gosh, they've got high blood pressure and this and a family history. I better really take a close look. And so they started seeing more apparent decay, perio, functional risk. And then so the treatment plans got broader, and the amount of dentistry that patients were saying yes to increased. So case acceptance rose dramatically because everybody from the financial planner to the dental assistant who'd been there for 2 weeks really understood that we were looking for complete care that was of the highest and best interest to the patient. And then you just kind of let go of what they say yes to and handle that through financial options or what it is. I can't believe we've been going 20 minutes on this one question. You have such deep knowledge. I'm blown away. Chad, what are you thinking here?
Well, what's cool is how someone would start that then is even even if they were just doing it on their own and they wanted to have a lunch and learn where they sat around, they already dedicated time as the owner to say, here's what my parameters are for healthy and unhealthy being the low and high risk. And then maybe in the middle saying, here's our medium risk, because medium is somewhat arbitrary. It's a Brian Regan joke called extra medium. And because it's like, he wants an extra medium. How do we?
Medium for me says that there is area where the patient could influence it with their lifestyle.
Good call.
Right. High risk is they're dedicated to, sucking Altoids and chasing it with Mountain Dew, and there's nothing I can do. Right?
Yep.
So low risk is they don't have any of this going on and everything looks good. But medium is like, what are you willing to do at home? Because it could really tip the scale if you're willing to take some lifestyle risk. So I kind of, that's my medium, is how much control and influence is in the patient's hands.
Nice. I do like that. So then the other thing that I was writing down as I'm taking notes, Patti, but when we talk about having these risk parameter discussions with our teammates, what it does is it primes the pump, as Vicki explained, so that way we can see more treatment. That way we're taking better care of patients by using the risk factors, looking over the health history more in depth, and trying to look at the patient as a whole. And they should be wowed by the fact that this isn't typical for a lot of offices. I'm proud to say that as a profession, I feel like we're getting there more and more. We're starting to see the light. So some listeners might say, oh, I do that for every patient, and good for us. Good for you if you do that. But this isn't every office.
It's definitely not every office. And I've worked with offices sometimes for many years, and you still have to go back and revisit this, because you have to bring them back to that foundation. Because if people start letting that slip, you do see treatment acceptance go down. You start seeing some things shift, and I go, okay, let's go back. It's like Bruce says at the front of the room, and Summer goes, you're not talking risk factors, Bruce. You're not talking about risk factors. Yes, I am. Well, no, I'm not. No, you're not. And you got to have somebody in your office that holds you accountable to that too. So getting your hygiene, everybody on your team on board, but your hygienist can be so fantastic for co-diagnosing. And I think often the assistants and the admin, they don't get credit, and they should, because assistants, get patients started for every doctor visit. They're the ones that bring patients back for limited exams or emergency exams. Well, they can start that risk factor conversation right with them and take a look and be a co-diagnostician for the doctor also. And admin, when you're talking treatment options at the front, not so much treatment, but your financial options, you get to bring in that information into it and how important this is for improving the patient's health. Because our goal is to get our patients healthier. And sometimes it gets lost in being productive. Our goal is to get them healthier. And if we're getting them healthier, the productivity will come.
Patti, I think we're going to pause right there. I'm wondering, you said hygiene, and since you were a hygienist and you've done so much wonderful foundational work for our hygiene program, could we get you and Michelle Hudson and Catherine Gilliam and Katie Cameron to come back on our program sometime soon?
I would love that. And because I kind of want to plug, one of the reasons this is, I've created modules on all of these things, and it walks you through the calibration exercise, and it walks you through how to review a medical history. And so all of those things are going to be launched soon for PDA, and we have such fabulous clinical hygienists that just know this oral systemic stuff better than I do, because they're clinical and they practice it, every week in their practices. So we would love it. Absolutely.
Well, I'll make sure that we put that in the show notes, so anybody that wants to do online education with Patti Sooy on case acceptance, on medical dental risk factors, and how to get this incorporated. We do have that program rolling out really soon, so we'll make sure we get a link to that. I love it. I've been looking forward to this time a long time. Like, I get to talk to you all the time, and I'm so excited for our listeners that they get to hear the brilliance that you bring. Chad, I believe you have a question for Patti.
Yeah, this has been great, Patti. Thank you very much. So we have to finish on something a little bit more superficial so as not to have it so deep. as Porphyromonas gingivalis or whatever you call it. All right.
Exactly.
Speaking of pork, no. So my question for you, Patti, as you've heard from the other podcasts, you're one of our biggest fans. So you know the question coming. So I'll just get straight to it because the listeners know as well. Bacon or eggs?
I thought it was going to be tough, but on my little vacation last week, I took a picture. I'm going to send it to you. And it's perfect. And I thought of other big bacon fans, but it's bacon. And it says, I love you more than bacon.
That's pretty intense. That's marriage material right there.
Yeah, it is. It is. Just keep bacon in the diet. Yeah.
Well, everyone, thanks for joining us on our podcast here. We'll be looking forward to releasing our next episode of Everyday Practices next week. And you have a great week at your work and take care of your patients, take care of your team.
Bring your lunch or take us to the gym again next week to improve your everyday practices. Also, subscribe on iTunes, follow us on social media, and sign up for our email list. Now get out there and win with Everyday Practices.